Hello, everyone. It's a pleasure to welcome you today in this webinar. And on behalf of the Emirates Society of Ophthalmology, I wish you will enjoy a great evening. We have a pleasure to have the TFOS, the Tear Film Ocular Service Society, with us today in collaboration with Novartis. The TFOS is a world leader in eye health education. And I'm excited today and looking forward for a rich program. We have quick points for our attendees today. I would like first to thank Shuruk Khattab. She is from Novartis and helped in coordinating this program today. So if you have any difficulties or issue, you have the email on the screen right now, and you can email her. We have CME, and the certificate will be sent to you. And for the certificate of the workshop, it will take a couple of weeks to be sent to you. If you have any questions, please type them in the chat box. And I think it's time to start with our first speaker. We have Professor Jennifer Craig. She is a professor of optometry at University of Auckland. She is a world expert in dry eye disease and published several papers, and she led also several workshops of TFOS. And she is kindly joining us from New Zealand, which is around 5 a.m. In her time. Thanks for joining us. I think I wouldn't delay you anymore. You can start your presentation. Another point is we will keep the questions at the end. Professor Craig, the podium is yours.
Cool, thank you very much. I'll just share my slides here. Are you able to see that? Is that working?
Yes.
You can confirm you see my slides. Thank you. Thank you very much for the introduction. And thank you for the opportunity to speak tonight. Yes, for me, it's very early in the morning, 5:30 a.m. But it's always a pleasure to join you and to join with my colleagues today in talking about TFOS DEWSII and the outcomes. So this was an ambitious initiative, as you may know. It was driven by the amount of research that's available in the literature. There's so much information has been published, and because we want to be able to bring all that information together, consolidate that information, understand what we know, and understand the gaps in the literature. TFOS does that by bringing together 150 experts in this case, in an initiative that took 2.5 years, people from 23 countries producing a report that was 400 pages in length. So you'll be glad to hear I'm only doing a very small part of that, just the highlights, and I'll be talking about the definition and classification and the epidemiology. So I will move my slides forward. I'll try. Yeah. So these were the 10 reports that were published, and as I say, we're only going to just give you some highlights of them. But the reports, if you would like to see them, are available on the TFOS website, the Tear Film and Ocular Surface Society website at www.tearfilm.org. And these are all the reports are there, but the executive summary is only 13 pages long. So if you want to just get the highlights in a written form, that would be the way to go. So my presentation is what is the dry eye and in whom does it occur? We're going to cover the what, whom, why, when, where of dry eye tonight for you for the clinical aspects. So the TFOS DEWSII revised the definition of dry eye disease. So dry eye now is a multifactorial disease of the ocular surface, characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms, in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. So we're talking about the tear film, that's the main focus. And I mean, as we know, it's a tiny little structure, but it's incredibly important. It has important optical, mechanical, nutritional, and defensive properties. It needs to be a really good refracting surface. It needs to be able to allow the lids to blink. We need to be able to get oxygen to the avascular cornea, and we need to protect the eye with antimicrobial agents. And it does that through a number of components. We've got mucins near the corneal edge. We then have aqueous, and we have the lipid layer on the surface. So going back to the definition, obviously it rolls off the tongue. It's quite a long definition, but it's a lot of important information that's in it, and a lot of time was spent choosing the words carefully. I just want to highlight a few of those words. So the first one, disease. It's recognized as a disease, and that's important. The committee and the consensus was that this was incredibly important to call it that, not just because of the impact on the tissues themselves, but because of the impact on the people who are affected. A massive impact on quality of life. If you look at quality of life surveys in the literature, you see that dry eye is rated as equivalent to conditions that potentially people think of as much more severe, like angina or kidney disease requiring dialysis. But in terms of impact on quality of life, these are equivalent. It has a huge impact on productivity, and it's not just in absenteeism at work. It's not just people not able to turn up, missing work. They actually turn up at work, but often can't do the job that they're trying to do because they're so badly affected by their eyes. And that's what we describe as presenteeism. There's associations with mental health disease, and there's a huge financial burden, both personal for the individuals involved in paying for their treatments, but also globally in the loss of work. We're talking about, when we talk about dry eye, we need to dictate what area we're talking about. So when we're talking about this, we're talking about the ocular surface. The ocular surface is not just that tear film that I showed you, but it's all the interrelated components. There's the lacrimal gland, the conjunctiva, the eyelids, the cornea, so the cornea, the conjunctiva, all the glands associated with it, and the neural reflex arc. If we don't have good sensitivity in the cornea, that can affect the way in which the tears are stimulated. And then there's a new phrase. So those other ones were recognized in the previous definition, but in this revised definition, some of the wording changed, and this is probably the key part, and that it's characterized, dry eye is characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms. So basically what it's saying is that you need to have both signs and symptoms in order to have dry eye. So the loss of homeostasis is an imbalance in the tear film. So where the tear film is out of kilter, where we can't, the tear film can't function the way it does normally because something has gone wrong with it, and that's the clinical signs that we can pick up. And then the symptoms have changed a little bit in the way that they are phrased. We used to say discomfort or visual disturbance. And these are still very, very important symptoms. They're probably our key symptoms, but they're not the only symptoms. We recognized from this global workshop that people in different parts of the world use different terminology. And so it's just a broader phrase to allow us to encompass all of them. So signs and symptoms. And then the last part is about all the etiological factors that are part of the vicious circle of dry eye disease that my colleague, Professor Gomez, is going to talk about at the end. Or after me, sorry. So then we classify dry eye. So why would we do this for diseases? Well, generally it's for us as clinicians to be able to improve the way in which we deliver patient care. If we understand where the patient falls in the picture of all the different diseases, then we can offer more targeted treatment. And so the classification of dry eye disease was also revised in the workshop. So this is the classification system, and if you haven't seen this before, it probably looks a little overwhelming. So I'm going to break it down to describe it. So first of all, we're going to have a look at the bottom part of the diagram, because that's the part that's consistent with the previous workshops, and it's taking the patient with dry eye disease and recognizing that there are two main subtypes, aqueous deficient dry eye and evaporative dry eye. But these are not distinct. often people will have a mixture of both. They're not completely separate. So patients often will have some signs of aqueous deficiency and some signs of evaporative dry eye. More commonly, it's evaporative dry eye. So you can see that yellow area is slightly larger than the other to recognize that. And that's been depicted now in the diagram to make that clearer. We always did recognize that they were not mutually exclusive, but this is a little clearer now. And the idea is that we need to restore this for anybody with dry eye. We need to target as best we can the problem that's gone wrong and try to fix that. And we'll be hearing more about how we can do that by careful diagnosis and management later. So then the top part of the diagram, and this was allowing us to take the patient sitting in front of us, to take a patient-centered perspective and try to work out what kind of patient we had in front of us. So when patients present, they may present with or without symptoms, and they may present with or without signs. And that's recognized in this diagram. So let's go to that top part now and look at the 4 different ways in which patients can be considered when they appear based on their signs or their symptoms. So first of all, the patients that do have dry eye disease, as we said from the definition, they have to have symptoms and they have to have signs. They have to have both of those. And what this diagram here is showing, the part that's highlighted, is that in the absence of masquerading symptoms due to a differential diagnosis, if we can exclude differential diagnoses, then patients with symptoms and signs of ocular surface disease will have dry eye disease. It's a subset of patients with ocular surface disease. That's the only ones that have dry eye. Outside, we've got patients who have symptoms, but they don't show any signs. In this case, it may be because the patient is very early in the disease process, so they are experiencing symptoms perhaps in a provocative environment, a very dry environment or something. But maybe when they come into your office, they don't show any signs at this point. It's important for these people to be watching them carefully to make sure that they don't develop signs and giving good education in order to try to prevent the development of dry eye for this group. The other group who have symptoms that are massively out of proportion to their signs are those with neuropathic pain. And that can occur in patients with chronic pain syndrome, with chronic pain. So perhaps with something like dry eye disease, you can actually, over time, it can actually affect the nerves and cause an oversensitization of the nerves. This causes actually structural and functional changes in the nervous system, in the somatosensory system. And that can't be fixed with our dry eye treatments, because this is now a problem of the nerves. It's not a problem of the ocular surface per se. And so this needs pain management independent of dry eye. So it's important to recognize that group. On the other side, we have the patients who are asymptomatic but show signs of ocular surface disease. So you can say these patients have ocular surface disease, but they don't necessarily have dry eye. They may be incidental findings, for example, where the patient turns up looking for surgery or for contact lens fitting. And you identify that they have frank signs of ocular surface disease. Now, it's important to manage those patients, especially preoperatively, because we know that, and Jose will talk about that, that surgery, for example, is one of the triggers for dry eye in some people. It's one of the triggers for the vicious circle of dry eye disease. And then otherwise, it might be, again, a problem with the nerves. But this time, instead of oversensitization, we've got a loss of sensitivity. And that can occur in dry eye because patients sometimes lose the density of the nerve in the subbasal nerve plexus within the cornea. And so they may not feel the symptoms associated with changes that are in their eyes. But obviously, to protect the eye for future, it's important we manage those patients. But it's important we know which group they kind of belong to. Patients will have different expectations, and the practitioner may have different expectations depending on the combination of signs and symptoms. And then we've got the final group are the patients, or the people who turn up have no signs and no symptoms, and that's the group that we are relieved to be able to call normal. So that's our 4 different sets of patients. So that's the overall classification system, and you can see beside that picture there we have little orange markers, and that shows you where the reports provide the information. So if you want to go to the reports and dip in and find out a little bit more information about any one of those topics, you can do from those individual reports. So the benefit of having that definition and classification is that it helps us differentiate between dry eye disease and associated conditions, the ones that may masquerade as dry eye disease. If we know which patients have dry eye disease, we can help them better. So this is important. The classification system recognizes patients with signs without symptoms, signs with symptoms, and the converse. So that allows us to separate those patients into those different groups and understand where we're from. And then finally, it recognises that aqueous deficiency and evaporative dry eye are not mutually exclusive disease subtypes, but can coexist. Patients can have features of both, in which case it will be important to manage both of those. So just to finish off, I'm going to just take a little bit of time to look at the epidemiology. So in whom do we see this dry eye disease? How common is it? So in the epidemiology report is a completely separate report, which gives a lot of information. But the key information they came out with was about its prevalence and its risk factors. So for prevalence, dry eye prevalence ranges from 5 to 50%. That came as a bit of a shock to me when that was the outcome, because that's not very specific. I'm not sure how helpful that is for us, but there are reasons why that occurs. I mean, basically what you're saying is this: if this is my population in front of me, perhaps the people suffering from dry eye could be just this guy, or could actually be all of those people. That's a big span. And I mean, the reason that we get that difference was recognized in the report. And it's the fact that these studies are collected from all over the world. They're using different criteria, but they're using different definitions of dry eye disease. Different, if you say to somebody, do you have some symptoms when you use a computer for a long time? Do your eyes go a bit dry and irritated? Many people would say yes. Probably about half the population. Whereas if you say, have you had your dry eye disease diagnosed by a clinician and been given a formal diagnosis and treatment for dry eye disease, that would be a very much smaller group. So this is why it is really important to have a definition that we all stick to and criteria that we use, diagnostic criteria, so that we can narrow down that prevalence rate in future and really understand the true prevalence of the disease. Risk factors are the other main thing coming out of the epidemiology subcommittee report. And they divided those into, and I apologize, it's quite small, but they divided those risk factors into ones that were consistent, probable, and inconclusive. And that was based on the level, the quality of the literature that was available. This whole report is based on the literature, so it's very clear what information we have at the moment. And so in terms of consistent, non-modifiable risk factors, and non-modifiable ones are the ones we're stuck with, we can't do anything about. Some of the key ones were aging, female sex, Asian race. We know those people are more, as you get older, you're more prone to dry eye. Female sex, Asian race, meibomian gland dysfunction, if you have a predisposition to that, or connective tissue diseases such as Sjogren's syndrome. Here's just one of the graphs from the report, which shows that women are more commonly affected by men, and you can also see that increase with age, with time. But the pinker bars compared to the blue, you can see that the females are showing higher rates of prevalence across the board, pretty much. If we look at the information that was used for the report and the information that's been published since that time, we see the increasing prevalence of dry eye with age, and that's for aqueous deficient and evaporative dry eye. And that occurs, you can see changing features that occur across the different decades associated with dry eye disease, and we can be looking out for those things like staining. You don't see it until the very end, but some of the signs like gland dropout you can actually see quite early on. And we have information, we're learning more information about the ethnic differences in dry eye disease and the Asian predisposition to that. And that seems to be related to a lot to eye closure, or incomplete blinking is one of the features that seems to be important in that area. In amongst those risk factors, we also look at modifiable risk factors, and these are the ones that we might be able to do something about. So as clinicians, these ones are really important to us, because that's how we can educate patients, we can learn what people are doing to encourage the dry eye that's appearing, so that we can try to get them to stop, so that we can try to change those factors, modify them in such a way that patients are less affected. And again, there's a range of ones that are consistent, the ones that we have the most evidence about, versus some that we don't know so much about. And that's kind of where we're going in the future. We know lifestyle, for example, is something that's very important, the environment in the things that we choose to do. And so it's great that TFOS has embraced that, and they've just launched the next workshop after TFOS DEWSII, and that's a workshop, A Lifestyle Epidemic, Ocular Surface Disease. And there we'll be looking at a whole range of different factors, things that we do to ourselves and things that we expose our eyes to that may cause a problem for our eyes, so that we can understand, again, evidence-based workshop, having a huge number of people across the world. I'm very proud to be chairing that one, and all the guys who are speaking this morning are also a part of that as well. And so it'll be great to come back in the future, hopefully, and be able to talk about some of the factors that are important and how we should be managing our patients. Thank you very much for your attention. I'll just stop the screen share now.
Thank you, Professor Craig. Very informative talk, and it was a very good introduction to classification and disease symptoms and sign. Thank you. And as I said at the beginning, we will keep the question at the end. Sorry to keep you even longer with us.
No worries.
As we agreed at the beginning, we will keep the question at the end for the audience. So you can type your questions, and we will collect them, me and Dr. Saleh, and we will do the discussion at the end of the presentation. Our next speaker, Professor Gomez. Professor Gomez is a professor at the Department of Ophthalmology at University of São Paulo, Brazil. He is a world expert in dry eye disease, and he has published several papers. He is a director of the Ocular Surface Advanced Center, and he has major contribution to the TFOS. Professor Gomez will be talking about the pathophysiology of dry eye disease. Professor Gomez, the podium is yours if you would like to upload your presentation and start.
Thank you, Murad. It's really a pleasure to be part of this wonderful event. And I want to thank Novartis, the Emirates Ophthalmology Society, and TFOS for giving me this opportunity. So, one sec. Okay, can you see my slides?
Yes.
Good. So this is my financial disclosure. And well, I will divide this talk in two parts. The first part, we are going to review some aspects about the ocular surface. Jennifer gave a wonderful introduction and made my task easier. But I want maybe to review some of those important concepts. Then we're going to discuss a little bit about the pathophysiology. And in the second part, we are going to discuss a very important chapter of the TFOS DEWSII, which is iatrogenic dry eye. And I will keep part of this talk on this important topic. Well, we know that the ocular surface comprises a continuous epithelial layer composed by the conjunctival epithelial, the limbal epithelial, and the corneal epithelial. And all these very specialized epithelial cells to keep their phenotypic characteristics and their function, they need to be lubricated. And this lubrication is provided by the tear film, which is made of the mucin layer that is produced by the conjunctival epithelial cells, especially the goblet cells, but the corneal cells also produce some of the mucin layer. Then we have the aqueous layer, which mix with some mucins that are secreted from the epithelial cells of the most important and the main layer of the tear film. So it's the aqueous and mucin layer. And then we have an external layer of the tear film, which is the lipidic layer, which is made from the secretion of the meibomian glands. And this lubrication is extremely important, but it's not only these three layers. We must be aware that especially in the aqueous layer, we have a lot of other components. Actually, you have more than 100 or more proteins like lysozyme, lactoferrin proteins, which are very important to protect the ocular surface against invasion of microorganisms. We have electrolytes, we have cytokines, we have proteases, we have EGA, immunoglobulins that are also important for the protection of the ocular surface. So the tear film not only lubricates and keep the phenotypic characteristics of the epithelial cells, but also provides all the nutrients which are extremely important. And this is especially important for the corneal epithelium, which is the most important part of this ocular surface because it covers the transparent main structure for the optical system of the eye, which is the cornea. So we know that each of these compounds of the tear film are important. We know that the lipidic external layer of the tear film is very important to protect against evaporation. So it gives a stabilization of the tear film. We know that in the aqueous mucin layer, we have protection and nutrition as the main roles of this important layer of the tear film. And we know that the mucin layer, either the transepithelial mucins or the mucins that are secreted, are extremely important for the adhesion or the interaction of the tear film with the ocular surface. So when we have the eye open, all this structure, especially the mucin layer, keeps the tear film adherent to the ocular surface, maintaining all the important characteristics of the epithelium. But we need to have this lubrication in a continuous mode. So we need to keep the eye moistened all the time. And how is it possible? Well, we have a very complex net of nerves that are under the basal layer of the epithelium. And those nerves are extremely sensitive to the changes in the environment. They have receptors to temperature, to different osmolarity, to different stimulus, and they keep an afferent information that will drive to efferent nerves, especially the parasympathetic nerves, which are going to innervate the lacrimal gland, which is going to produce the tears in a continuous mode. At the same time, we have some motor innervation of the facial muscle or the orbicular muscle. So it's the facial branch, the motor branch that is going to innervate the orbicular muscle, which is going to provide the blinking, which is very important to decrease the evaporation and also to make this change of the lacrimal film when the patient blinks. So this is very important to keep a functional unit, homeostasis of the ocular surface and lacrimal gland unit. And of course, the neuronal loops, which keeps the eyes continuously blinking and producing tears, are an extremely important component of this functional unit. So when you have exogenous factors like the use of contact lens or a surgery that damage the nerves of the cornea, or when you have medication that decrease the production of the aqueous layer by the lacrimal gland, or other environmental stimulus, or when you have an inflammation of the lacrimal gland, as it happens in Sjogren's syndrome, so it affects the production of the tears, or when you have a meibomian gland disease, which affects the production of the lipidic layer, which is very important for the tear film stabilization, then you have a break in this homeostasis, and you have the dry eye disease with its symptoms. So the dry eye, according to the DEWSII, has its definition, which was revealed. It's now a little bit complex, but it's a very complete and updated definition that really make us make us able to differentiate dry eye from the other diseases that affect the ocular surface. And I won't repeat the definition, but want to highlight some words of the definition to start the introduction of the pathophysiology. Tear instability, hyperosmolarity, inflammation, and neurosensory abnormalities. Those are very important components of the pathophysiology of the dry eye disease. And maybe one of the most important and the trigger of the dry eye pathophysiology is the increase of the osmolarity, the hyperosmolarity that happens in both types of dry eye, either with the evaporative dry eye or even in the aqueous deficient type of dry eye. But the fact that in both types of dry eye, we have an increase of the osmolarity, and this increase of osmolarity causes a lot of damage in the ocular surface. It causes loss of the micropliculae of the superficial epithelial cells that makes this interaction with the mucin layer and all the tear film. It also increases the levels of matrix metalloproteinases, which are proteolytic enzymes that can damage the epithelial cells. We also know that this increase of osmolarity can be a trigger of some pathways of inflammation, like the MAP kinases pathway of the ocular of the inflammatory process. When you have damage in the ocular surface caused by this hyperosmolarity, which is delivered from both types of dry eye, then you have exposure of antigens of the ocular surface, and the antigen presenting cells get these antigens and migrate to the lymphonodes, to the regional lymphonodes, and present those antigens to T cells. And then you have both from Th1 cells and Th17 cells. These lymphocytes migrate back to the ocular surface, and they are going to make or potentially process that starts with the hyperosmolarity. So when you start to have this type of situation, stimulating the regional lymphonodes and the immunological system, we start to have a chronic process of inflammation. And this is what differentiates and make us to understand those patients that come to our office complaining of dry eye with multiple artificial tears or lubricators, and they are not improving their inflammatory process. It's because it has already started the systemic involvement of the immune system, and you have a chronic inflammatory process of the ocular surface now. So this creates what we call the dry eye vicious cycle. So it starts with the increase of the osmolarity, the hyperosmolarity. This starts to cause inflammation, and the inflammation is going to go back to the ocular surface, is going to compromise the mucin layers, it's going to compromise the tear film, which is going to be more unstable. With this, you have more osmolarity increasement, hyperosmolarity, then you have this process coming and going in a vicious cycle way. So it's not only many times, not only artificial tears are able to break this vicious cycle, but sometimes we need, when you have this chronic inflammation, to use other strategies to treat dry eye. So after reviewing these aspects of the ocular surface and understanding a little bit more about the pathophysiology, now we are going to enter in this very important chapter, which is iatrogenic dry eye disease. And what is iatrogenic dry eye? Well, it's the dry eye induced unintentionally by a medical treatment of a physician or a paramedical professional. So that's the definition. And this is also a part of the TFOS DEWSII, which I had the privilege to coordinate with many doctors, surgeons, and researchers. And in this report, we could classify iatrogenic dry eye according to the cause. And as you can see here in our classification, iatrogenic dry eye can be caused by drugs, contact lens, surgery, ophthalmic procedures, and other conditions. So let's review some of these types of iatrogenic dry eye. The first one, and maybe the most common one, is the drug-induced dry eye. And as we know, we have a lot of topical medications that we use for treating ocular diseases. We know that some of them are toxic to the ocular surface. We know, for instance, the toxicity of some of the antiviral agents. We have the conjugates that also can be toxic to the ocular surface. We know mydriatics, cyclopedics, some topical non-steroidal anti-inflammatories can be extremely toxic, especially when the epithelium is open. The anesthetics is a classic product that can cause a lot of damage in the ocular surface. So besides those, we also have the anti-glaucomatous medication. And this is a special group of medication that it's interesting to open a parenthesis to discuss a little bit more of the anti-glaucomatous medications. First, because it usually glaucoma, especially the open-angle glaucoma, it starts in an age where you have less production of tears. So it happens more after the 50s and 60s, when patients are more prone to develop dry eye. And that's the reason why patients with glaucoma develop not only the most simple cases of dry eye, but also moderate and severe types of dry eye. So they are more common in these patients with glaucoma that are using anti-glaucomatous medication. And you can see in our practice, right? Patients with red eye, with keratitis, with sometimes even other types of ocular surface problems that are due to the anti-glaucomatous medications, especially in those patients that are a little bit older, that are starting to have glaucoma and starting to use anti-glaucomatous medication. And of course, most of the anti-glaucomatous medications have preservatives. And the preservatives are important for the glaucoma, anti-glaucomatous medications because it breaks the junctions of the epithelial cells, improving the penetration of those agents that are going to decrease the IOP, the intraocular pressure. But of course, some of these preservatives, especially the benzalkonium chloride, have a very, very profound effects on the cells of the ocular surface. We know that not only that, but it also destabilizes the lipid layer, the aqueous layer of the tear film, and so it's very, very toxic to the ocular surface. We even know now that the BAK is extremely negative to the nervation of the cornea. So, especially when patient uses more than one medication, multiple medications, so you add toxicity from one to the other, and of course, the degree and the severity of dry eye and ocular surface problems in these patients is getting worse and worse. So it's very important with this to keep in mind to try to use anti-glaucomatous medications with less toxic preservatives or ideally without preservatives. And that's the tendency now to keep these patients with glaucoma with non-preservative anti-glaucomatous medications. Well, going back to the drug-induced dry eye, we have also systemic drugs that can induce dry eye. We have medications like some antidepressants, antihistamines, a lot of medications, antiparkinsonians, anxiolytics, opioids. Many medications decrease the production of the aqueous layers of the tears. So systemic drugs can induce dry eye, and that's you need to keep in mind, especially when patients are taking more than 1 or 2 or 3 of these medications, that they need to be discussed with the patient or with the physician with the patient to see if we can decrease the number of those medications or at least be aware and try to treat these patients more aggressively to deal with this problem of decreased tear production. We have the National Registry of Drug-Induced Ocular Side Effects, which is a document that analyzes each of the systemic medications and their effects in the ocular surface. Iatrogenic dry eye can also be induced or associated with dry eye. And this is a very important chapter that was discussed years ago in the TFOS workshop on contact lens discomfort. And we know that there are different variables that need to be considered both in terms of the contact lens use, of the type of the contact lens, design, fit, the lens care, and also the environment and how the patient is using the contact lens. And we know that sometimes this type of situation can progress to a permanent discontinuation of the lens. So this is a very important topic that we need to remind, and it's an iatrogenic cause of dry eye as well. But maybe the most emblematic type of iatrogenic dry eye is the one caused by surgeries or procedures. And speaking of the surgeries, we have a couple of surgical procedures that can cause dry eye. Maybe the most common one that was extensively studied in the last years was the dry eye disease after LASIK. We know the important, a lot of ophthalmologists started to observe dry eye signs and symptoms in more than 50% of the patients who had LASIK. Of course, some of these signs and symptoms improved after a few months, but it happens in a big amount of patients after this type of surgery. When you see the pathophysiology of this post-LASIK tear dysfunction, we notice that probably the main problem with the the LASIK surgery is the cut with the microkeratome of the intracorneal nerves. And with this, you decrease sensitivity, we decrease the afferent pathway of the nervation, so we decrease tear secretion, decrease the blinking, and we also can have an effect on the meibomian gland secretion. And so this causes a lot of the problems in the ocular surface and the dry eye or the neuropathic problem of the caused by the denervation caused by the LASIK surgery. We know that these studies with confocal microscopy helped us to understand more about the corneal nerve denervation and regeneration of the nerves after LASIK, and it made us to understand that, for instance, the use of femtosecond laser to make LASIK may be a little less harmful to the innervation of the cornea. We also know that other refractive surgeries as SMILE, when you have a much smaller damage of the nervation comparing to the LASIK, can be an option in patients that have dry eye and are going to be or to undergo a refractive surgery. We also have other surgeries. Keratoplasty change completely the nervation of the cornea and also can cause a problem of denervation and decrease in the blinking and of decrease in the tear production. We also have the cataract surgery, which is now more studied. And this is a very important topic because we know how frequent is cataract in the older age population. And a lot of studies are coming in the literature analyzing this situation. We know that the dry eye happens after the cataract surgery. It gets worse in the first 30 days and then improved after 3 months. When you try to understand the mechanism behind it, we know there are problems with the drops that patients use before and during the surgery, for instance, the anesthetics drugs. We have also denervation caused by inflammatory factors. We know that there is a decrease in the lipid layer of the tear film of patients that undergo cataract surgery. And we also have important aspects related to the microscope light toxicity. So some of the aspects that are involved in the dry eye caused by cataract surgery. It's also important, the post-op implications. And this, we know that a lot of patients, especially the ones that are using or that are having a premium IOL, a multifocal IOL implanted, those patients are extremely have a lot of dissatisfaction in terms of the visual acuity after the procedure. So this is caused by dry eye, and we know the importance of the tear film in vision. And so patients sometimes got this very expensive multifocal IOLs, and they started to see very badly after the surgery. And this is mostly related to the problem of the tears that these patients have. Other surgeries, lid and conjunctival surgery, and here one is that sometimes we forget about it, but that's very important, the blepharoplasty, where some of these patients get lagophthalmos after the surgery. They don't close well their eyes, and we know the problems that blepharoplasty and other procedures of the eyelids can have. And this is a topic that we studied in our university. This is part of a thesis of a student that compares the pre and post blepharoplasty together or without the laser, the CO2 laser. And we found that most of these patients develop a mild to severe dry eye in the first month. Some of these patients, especially the ones who didn't have the laser together with the blepharoplasty, they developed a problem in the ocular surface that needed to be addressed. Otherwise, this is going to cause chronic inflammation in the ocular surface. Other surgeries, glaucoma, vitreoretinal strabismus, and procedures can also cause iatrogenic dry eye. Cross-linking, detoxinum botulinum, cosmetic procedures, and sometimes very funny cosmetic procedures, as the tattooing of the conjunctiva, can cause this type of condition. So it's very important to avoid these problems. First, to diagnose dry eye before indicating a surgery, especially refractive surgery or even cataract surgery. So a very good diagnosis, which is going to be discussed in this event, is extremely important to do a very detailed exam to diagnose dry eye before indicating treatments. Then a medical advice, and of course prophylaxis. Of course, when you treat dry eye before doing a surgery, or maybe contraindicate a surgery in a very severe dry eye, that's a way to avoid problems related to dry eye disease. And of course, the treatment that is going to be discussed later in this symposium. So in conclusion, we saw that the ocular surface, tear film, secretory glands, and neuronal system comprise a physiologic functional unit. Dry eye is a multifactorial disease, which the pathophysiology includes tear film instability, hyperosmolarity, ocular surface inflammation, and neurosensory abnormalities. Iatrogenic dry eye is a very important type of dry eye and can be induced by topical systemic medications, contact lens, ocular surgeries, and procedures. And treatment should address not only lubrication and inflammation, but also the denervation problem, as well as prophylactic measures. So I want to thank you for the opportunity, and I'll be glad to answer any questions at the end of this program. Thank you.
Thank you, Professor Gomez, for this great informative talk. I just wanted to highlight the very important point that you mentioned about the vicious cycle of dry eye disease. This is a point that I always talk about it with my trainees, that it's very important to break this cycle to help the patient. And sometimes just giving lubricant, as you said, is not enough. So thanks for mentioning this. I'm sure there will be a great discussion at the end. We are a little bit behind in terms of the time, so if you don't mind, I'll introduce the next speaker. We have Professor James Wolfson. He's a professor of optometry at Aston University in Birmingham. He published several papers, more than 200 peer-reviewed academic papers, and he will be giving us the talk about the diagnosis of dry eye disease. Thanks, Professor Wolfson, for joining us today. And the podium is yours.
Thank you, and thank you very much for the invitation, and to Jen and Jose for setting the scene so well, which will make my job a lot easier. So I'll be talking to you about the diagnosis of dry eye, which of course has come up a couple of times already, about the importance of doing that to make sure that we're all talking about the same disease. In terms of my financial disclosures, they are here. But of course, the report, as with all of the TFOS reports, was put together by a group of individuals and has been published in the Ocular Surface journal, and you can see it available here freely. So let's think back to Jennifer Craig's talk, and in terms of the differential and diagnosis of that patient, the subclassification for TFOS DEWSII started with the patient. According to the definition, they must have both symptoms and signs. So there's no such thing as dry eye which doesn't have symptoms. That is ocular surface disease, of which dry eye is a subset. But of course, we've got to then, if we're going to make our diagnosis, make sure that this is not a disease that could mimic dry eye, such as allergy or infection. Make sure that the patient meets some standard criteria, both for those symptoms and signs. And if that's true, then we can move down to the subclassification and then on to the treatment. But of course, the problem of standardization is that there are lots and lots of different tests for looking at the ocular surface and the tear film. And you can see just some of them here in terms of things like staining, tear film, do we do it with fluorescein or without fluorescein, indirect measures of inflammation such as redness of the eyes, symptomology, even volume tests such as Schirmer's or phenol reds, so a huge range of tests. And yet it's really important that we standardize. So when the committee met, it looked at all of the tests that people had previously suggested would have some kind of diagnostic ability for dry eye. And as you can see, there are many tests from symptoms and visual disturbances, tear film stability and volume and composition, to ocular surface damage and inflammation, and eyelid aspects as well. If we look at these, of course, many of them have a sensitivity and a specificity, so how good they are at picking out those people who we put in our disease group compared to our control group, and also for making sure that they don't diagnose those people who are in our control group. But if you look carefully at the small print of the tables on these sorts of tests, they note that there are significant biases. And those biases mainly come from the selection of the patients. Normally, we have some criteria for our normals, we have some criteria for our disease group, and often there are people in between who don't meet either criteria. And then for our disease group and our normal group, if we're looking at very severe disease and very tightly controlled normals, then of course the sensitivity and specificity of any test will look better than if those two groups were closer together. Likewise, we have to choose our disease group in the first place, and if they are chosen related to something about the test that we're looking at, such as tear volume, then of course the sensitivity and specificity is going to look very good. If our test is a volume test, but we've chosen to diagnose our group in the first place based on stability, then it won't look so good. So as you can see, there's some natural biases there. So not only are we looking at sensitivity and specificity, but also the non-invasiveness. The tear film is very thin and very fragile, and therefore any test that is disruptive to the ocular surface could affect the results. And we want to be able to perform this in clinical practice so we get good information on diagnosis and feed that back to our patient. So essentially, at the end of the day, the committee selected from those tests and the literature, the academic literature we have, those tests that gave the best of all criteria. And those are the core tests now that everybody should be using for their diagnosis of dry eye. That's not to mean you need to get rid of your favorite other tests, because they can be useful for you in choosing, for example, the best treatment to use. But everyone should be using the same standard core tests for their diagnosis. Otherwise, we do not move forward in terms of understanding prevalence and risk factors and other information about dry eye and its treatment. So let's have a look then at how we do this diagnosis. So essentially, we start with our history and symptoms like we would do for any patient, and we're going to be asking them some questions about their eyes, the symptoms that they're getting, the conditions that they have, as we would do in normal practice. And we'll go through these in more detail in a subsequent slide. Also, as part of that history and symptoms, of course, we naturally ask them about their environment and what they do, and this will help not with the diagnosis, but with the treatment that Lyndon will talk to us in a few minutes about. But of course, we're going to pick that up in our history and symptoms. So what about the diagnosis? Well, the diagnosis is done in two parts. First, the screening, because actually doing the diagnostic tests takes time and effort and money. So in terms of screening, we have a symptomology questionnaire. We remember back to the definition, symptoms must be there. And the committee chose two questionnaires, and again, we'll look at those in more detail at a moment, with clear, distinct cutoffs as to whether they have a positive screening. If they have a positive screening and one of any of the homeostasis, loss of homeostasis markers, then it's a diagnosis of dry eye. So symptoms plus, well, it could be non-invasive breakup time. This is preferred to a fluorescein breakup time because that does disrupt the tear film. And if you do use the fluorescein breakup time, you'll have to swap the order of the test. Or it could be symptomology and osmolarity. So the salt balance on the front of the eye, which again has been shown to be diagnostic of dry eye, or symptomology and ocular surface staining, and not just lissamine green, not just fluorescein, but also lissamine green, and looking at the cornea, conjunctiva, and lid margins. So symptomology and any one of those 3 homeostasis markers will then give you a diagnosis of dry eye. So you can make a diagnosis without necessarily having all 3 of those sets of tests, but to fully diagnose dry eye and make sure that you pick up every person who has dry eye, those are the tests that you need. And then we move on to the subclassification before we then can go on to the management that Lyndon will talk to us about in a moment. So let's have a look then at, in more detail, at those tests. So let's start with those triaging questions. So we need to acknowledge that, of course, it is not just ophthalmologists and optometrists that look at dry eye, but also medical practitioners and pharmacists, for example. But there need to be some standard tests to help in that differential diagnosis. These will be standard tests that you're questions that you're using with your patients anyway to help identify those that are more allergy or more infection or maybe contact lens related, so that needs to be sorted first. The question in grey there about mouth dryness and enlarged glands, of course, is aimed at Sjogren's syndrome. That is part of dry eye, but of course there are comorbidities, so we don't want a pharmacist, for example, holding on to those patients and just giving them an artificial tear without a proper referral. So we start with our history and symptoms, which includes our triaging questions, and then we move on to our risk factor analysis as part of our history and symptoms. And you can see here at the table, again, Jen showed this earlier, a very nice way of breaking down the science on risk factors, whether they're consistent, probable, or inconclusive, and likewise whether they're modifiable or non-modifiable, use for a patient to know, but not something that we can change. And so many of those will fall in the categories that you expect, although some, like smoking, are still inconclusive for dry eye. So it's useful to have access to that table to have a good conversation with your patients. Then we move on to the diagnostic tests, and as we said, there are 2 stages to that. First of all, the screening, and then the loss of homeostasis markers. So for the symptomology, we've got 2 main questionnaires. The DEWSII, the Dry Eye Questionnaire 5, which asks about the severity and frequency of both discomfort and dryness, and then about the frequency of watering eyes. Or the very well established Ocular Surface Disease Index with its 12 questions, where it looks more at some of the environmental factors as well. You can see the cutoffs for each of those. These are really easy to do in practice. The patient doesn't even need to be in the consulting room, but these can be done before they come to you, so you can determine whether it's worthwhile doing your homeostasis markers or not. And patients like these numbers because it allows them to monitor how they change over time. And many of them fluctuate even without treatment, but obviously if you're trying to manage them, then it's very useful to be able to reflect back on these numbers. So that's the screening element, and then we move on to the loss of homeostasis markers for the other part of the definition. So first of all, the tear film stability, ideally done with a method of non-invasive breakup time with a cutoff of less than 10 seconds of an average of 3 readings being diagnostic together with symptomology. While we're doing that, these instruments, which are becoming ever more available, allow us to pull back slightly and also see the lipid layer, which is going to be very useful when we come to the subclassification. So that's your interferometry. Also, fluorescein is acknowledged as something that many people still use, great for staining, but disruptive for the tear film, so this would have to be done later in your sequence of tests. And again, there's some very good research from Jennifer's group showing just how undiagnostic actually a fluorescein breakup time is compared to non-invasive. So with this ROC curve, the closer the line is to the top left-hand corner, the more diagnostic the test. If you are going to use fluorescein, it has to be the absolute smallest amount to try and make sure that you don't disrupt that tear film in terms of your measurement. Then we have osmolarity. Of course, we now have point of care tests, and we have some cutoffs for the earliest one of those in terms of taking our measurements. This is a little bit different because we take a measure from both eyes, one measure from both eyes, and we're looking not just at the highest value, but also at the difference between the eyes, because it's well known with all ophthalmic diseases that as disease progresses, values become more variable. So this is picking up the variability as a diagnostic criteria. And then finally, the third loss of homeostasis testing is to do with staining, both with fluorescein of the cornea, but also lissamine green for the conjunctiva and the lid margin. And here we're looking for the classic punctate spots, and we can physically count those for the corneal region, conjunctival region. For the lid margin, we're looking not at the line of marks, which of course is a natural tissue feature, but the spreading out of that lid wiper where there's been friction between the lid and the ocular surface, and we can measure both the width and the length of that to get our diagnostic criteria. Now, if we've got symptoms and one of those three signs, then we're safe to make a diagnosis of dry eye. And because we're all using the same tests, then we have standardization in terms of that. But of course, if we're diagnosing them with dry eye, we cannot stop there. We need to move on to that subclassification element to determine where on the spectrum between evaporative and aqueous deficiency they fall. So let's have a look first of all at the aqueous deficiency. We're looking for a non-invasive test. The recommendation was to use tear meniscus height. We can do that with a slit lamp, or if you've got an ACT, you can actually see the volume, and some very simple cutoffs in terms of the level of severity of aqueous deficient disease. As I said earlier, if you like using things like Schirmer's, that you can do on top of these tests to help you in terms of determining your management, but it is very disruptive for the tear film. Of course, the vast majority of patients have the evaporative form of the disease, and we're looking here at a range of lid-related measures. So meibomium gland assessment in terms of the expressibility, such as with an expressor or with your finger or a cotton bud, and the oil flow and type. We can look at myobography in terms of imaging the glands, such as with infrared light. We've already talked about interferometry, which we can do when we're doing our non-invasive breakup time by pulling back slightly and seeing the flow pattern of the lipid. We're looking at the blink and lid closure, very important, often picked up in my patients as one of the causes of dry eye, and that is something that we can do something about with exercises. And also the lid margins themselves and aspects such as keratinization, which again can stop the flow of that meibomium onto the ocular surface. There are a series of videos available on each of these tests, so you can see them and how they're carried out in more detail, and they're available through the TFOS DEWSII site, and they're just mounted on YouTube. So very useful again to check your practice against the standards, but also for your training of others. So in conclusion, we've had a look at the diagnosis of dry eye, emphasizing that it is signs and symptoms as per the definition, the signs from the symptomology questionnaire, the symptoms from the questionnaire, the signs from the homeostasis markers. Any one of those three plus the symptomology is a diagnosis, and that moves us then onto the subclassification. So that leads really nicely then for me to end here and to pass over to the introduction of Lyndon Jones, who's going to take us through the management then of the disease. Thank you very much for your attention.
Thanks a lot for the great talk. We are a little bit running behind. Just I would like to remind the audience to type their question in the chat box. And also there is a link for the certificate. Shuruk from Novartis, who kindly helped with arranging this webinar, will be posting it again just for those who attended the webinar later. Now I would like to introduce our last, but of course not last speaker of the day, Professor Lyndon Jones. He's a professor of optometry at University of Waterloo, and he has an interest and research focus in novel contact lens and ocular service environments. He will be giving us the talk about the management of and the therapy of dry eye disease. Professor
Thank
John.
you very much. Thanks for that. And thanks to my co-presenters for really setting this section up very nicely. So here are my disclosures. I work at CORE is the Centre for Ocular Research and Education. We work with a number of partner companies listed here, but of course this paper was very generic, so it's not intended to support any of these individual companies. So I was very privileged to be the chair of the TFOS DEWSII Management and Therapy Report. We had 15 subcommittee members. They came from a wide variety of backgrounds, so 10 countries, 7 different languages. And our report basically covered in great detail the management and therapy report. And obviously because of time, we're going to have to kind of highlight some of these. But for those of you who are interested, I certainly would suggest that you take the time to review the management and therapy report if any of the things that I talk about are of interest to you. Our committee really had 2 specific goals. The first being to undertake a comprehensive evidence-based review of current dry eye therapy and management approaches. Now, of course, it was current dry eye therapy and management approaches at the time that we wrote the report. So that was our first goal. Our second goal was to then take that information once we knew how well these variety of management and therapy options worked, to then develop, if we could, a strategy for the clinical application of those management and therapy options by developing a stage management algorithm. And I'm going to actually cover both of those. Now, as I said, it was a very long and very extensive report. As I'm sure you can imagine, there are lots of ways of being able to manage dry eye disease. We basically broke those areas down into 7 specific areas, the first of which being treatments for tear insufficiency. So these for your patients who are producing insufficient quantity of tears. Then there's the treatment of eyelid abnormalities. This was primarily related to those patients who produce an adequate amount of tears, but then primarily actually because of meibomian gland dysfunction, will have that tear film actually evaporate off the eye, so mainly for the management of evaporative dry eye. We had a large section on the value and importance of anti-inflammatory therapies. We've already heard that dry eye disease has an underlying inflammatory component, so these were the management to knock out that inflammation. There was an excellent section, and probably still one of the most comprehensive sections, about the surgical approaches to manage dry eye disease. There was a section, a very, again, extensive section on the role of dietary modifications, so how you could control the diet and impact dry eye disease. There was a nice section on local environmental modifications. And the final section was, again, I think a very useful section. It's not been covered particularly well elsewhere, and certainly I think worth reviewing, on complementary medicines. Now, of those 7 sections, the 2 that I think are probably the most commonly used and occur in many of the patients with dry eye disease are the first 2, the treatments for tear insufficiency and eyelid abnormalities. So let's look at those in a little bit more detail. In terms of the treatments for tear insufficiency, we broke those up into 5 subsections. We looked at tear supplementation, so how you could basically replace or mimic the tear film. We had a large section on lipid-containing supplements. There's a significant amount of information now around the use of lipid-based lubricants. We looked at the role of preservatives, so how valuable and what sort of patients would benefit from using either unpreserved or non-preserved drops, or those drops that use what we call safe preservatives or safer preservatives, so avoiding the use of things like BAK. There was a section on tear retention or conservation. So in those patients who basically are not producing that many tears, how could we optimize retaining those tears on the ocular surface? And the final one was something that's a little bit newer, which was on how to stimulate tears, either using drops or by, so using drugs or by using devices. When we look at the next largest section, which is the treatment of eyelid abnormalities, again, this subdivided up into this time 6 different sections. We specifically address the use of things like warm compresses, therapeutic gland expression, lid hygiene, very, very important for many of our patients. We looked at the role of lid debridement. There's a very nice section and good evidence these days that actually debriding the lids and actually unblocking the meibomian glands can be very useful. The role of prescribing blinking exercises, and again, the improvement of lipid quality. And all of that's covered in great detail in our report. And again, because of time, we don't have any opportunity to cover that in detail here, but I certainly do think it's worthwhile you taking the time to read the entire report, which you can download from the TFOS website. The final section that we looked at, so that basically constitutes the first goal that we had, which is to develop an evidence-based review that basically put all together the information that we have as to which of these many, many options actually work and what evidence we had for that. We then took that information and tried to develop a kind of stepwise algorithm such that if a patient comes into you, you've diagnosed that they have dry eye disease using the information that we've talked about in the previous presentations you've listened to this evening. How could we then take the products that are available and actually apply them to the patient in question? We came up with basically a 4-step treatment algorithm. And they're not mutually exclusive. So you could take advice here from steps 1 and, for example, step 2, maybe even step 3, and put them together. So they're not mutually exclusive. And by and large, as the patient's degree of dry eye disease progresses, so as their dry eye disease gets worse, then typically we'd move up these steps. So let's start with the simplest ones. First of all, the step 1, here, education. Education is very important. It's important to make people understand that basically if they don't continue to manage their dry eye, then it's not going to just simply go away. It's not something that you can easily make go away. So education is very important. We look at the role of the environment and dietary modifications, eliminating things like systemic medications, the value of using artificial substitutes, whether that be gels, ointments, or drops, and simply cleaning up the lids. Those are the simplest ones. If that doesn't work, you could then move on to the step 2. I've listed them here: non-preserved ocular lubricants, tea tree, oil treatment, tear conservation, overnight treatments, in-office, various management options, and things like prescription drugs. If that doesn't work, you can move up again to step 3, where we're looking at things like oral secretagogues, autologous and allogeneic serum eye drops, and that's also where we had contact lenses. So contact lens options being soft bandage lenses or rigid scleral lenses. And then the very severe patients, maybe we're looking at using an extended course of anti-inflammatory therapy, things like amniotic membrane grafts and surgical punctal occlusion or other surgical methods. So that was basically the 2 goals that we had. Now, of course, this report was published in 2017, and what's changed since then? Because when we look at many of the, or really the 3 presentations that you've looked at tonight, much of that information that was presented in 2017 in terms of things like diagnosing dry eye, its etiology, whilst there have been single papers that have been very valuable in terms of progressing us forward, the one thing that's changed a lot is management and therapy, and it's going to continue to do that. So if we think about that management and therapy in terms of the 2 goals that we had, first of all, let's look at what new products or devices are available. Well, we certainly see more dry eye disease devices under investigation or being approved, and there's growing evidence for their efficacy. We've certainly seen an uptick in the understanding of the role of scleral contact lenses in the management of dry eye disease. We've got certainly an explosion of things like IPL. We've got companies like Alcon bringing out iLux, Sight Sciences bringing out things like the Tear Care for, again, warming up the eyelids. We've got some in-office or at-home advanced lid scrubs, things like the New Sight Medical New Lids. And we've even got new devices such as the non-invasive neurostimulator from Olympic Ophthalmics, the iTear 100, which is applied on the external section of the nose that stimulates the trigeminal nerve to increase tear production. And so, again, this list is not complete by any means, but certainly we're seeing more dry eye disease devices. When it comes to drugs, what we're seeing very specifically is more prescription dry eye disease drugs being approved globally. In the report, we cover Restasis, which had been out for a number of years prior to 2017, and Xiidra, which was relatively new at the time. So it was covered, but certainly a lot more information on the value of that has since been published. But we're also seeing now 3 other drugs that have been approved in various places around the world. Cequa from Sun Ophthalmics, a cyclosporin ophthalmic solution. Icurvis from Santen, bringing out cationic emulsion of 0.1% cyclosporin. And the latest approval from Kala Pharmaceuticals, Isuvis, which is a corticosteroid indicated for short-term treatment of the signs and symptoms of dry eye disease. So certainly we've seen an increase in both products, so prescription drugs, non-prescription drugs, over-the-counter products, as well as devices. The second thing we talked about was that algorithm. And so, again, what information do we have since this report that's looked at what basically people are prescribing? And 2 of the other people that you've heard speak tonight, Professor Wolfson and Professor Craig, along with myself and a variety of other people, actually undertook, post the TFOS DEWSII report, an online anonymous survey, which was distributed to eye care practitioners around the globe. And in that, we included 6 questions on the management of dry eye disease, specifically in relation to severity and subtype. This was completed by over 1,100 eye care practitioners from over 50 countries around the globe, so pretty extensive. That paper has just come out in the Ocular Surface. It was published just a few months ago, and the conclusions from that are this. In terms of the most commonly recommended management approaches, pretty much what we suggested actually in our algorithm. General advice, first of all, so advice and education. Low and high viscosity enhancing unpreserved lubricants are being used by lots of practitioners globally, as are lid wipes and lid scrubs. So those are the most commonly recommended approaches. In terms of severity, some treatments appear to be being prescribed actually independently of severity. So even when we know what the difference is between the severe dry eye versus the mild cases, things like artificial tears and nutritional supplements span across that severity range. In terms of as the disease progresses and the severity gets worse, we see an increasing use of oral antibiotics, punctal occlusion, topical anti-inflammatory and immunosuppressants, securitagogues, biologics, therapeutic contact lenses, and surgical approach, which kind of actually falls in with that order that we suggested in our 4-step algorithm. Some other interesting points relate to the type of dry eye. James already mentioned about the fact that it's important that we differentiate between aqueous deficient and evaporative dry eye disease and how we do that. And I do think practitioners are actually using that to help them in their prescribing decisions. What we find for evaporative dry eye is that essential fatty acids, lipid sprays and drops, lid hygiene, warm compresses, IPL, antibiotics, whether it be topical or oral, seem to be more commonly prescribed for evaporative dry eye. When it comes to aqueous deficient dry eye, we're seeing an increased usage of punctal occlusion, therapeutic contact lenses, securitagogues, and biologics. So again, it is important that not only that we diagnose a patient has dry eye disease, but what type of dry eye disease. Often we'll see that patients won't specifically have evaporative or aqueous deficient. Usually they're on a continuum somewhere between that. And by looking at how severe they are and what's the predominant type of dry eye, that appears to be helping us in our management decisions, which is good to see. So in conclusion from that particular paper, we can see that dry eye disease management really does differ widely across continents and countries. there is a wide range of management strategies being utilized at each severity level and between subtypes. And what we're finding is that what's missing from this prescribing algorithm is actually good evidence to support that. And certainly there's a big push now at trying to characterize dry eye in an appropriate way and see whether we can specifically come up with an evidence-based review of, if you've got this type of dry eye and it's this severe, this particular management would be more appropriate for it. And that's starting to happen, but there's still a lot more work to do in that area. So in terms of summary, that we know that the primary goal of dry eye disease management is to really restore homeostasis on the ocular surface. The chronic sequelae require ongoing management, not short-term therapy, and that's very important that we get that across to the patient. The management certainly is complicated by this multifactorial etiology, and the best effort should be made to identify the degree to which evaporative dry eye, often due to meibomian gland dysfunction, aqueous deficient dry eye, and other ocular surface conditions are contributing to the presentation, and certainly determining the major causative factor really is critical to appropriate management. And if we don't do that, then we're unlikely to do the best for our patients. So not only appropriately diagnose dry eye, but go into that subtyping and see where on that continuum they are between evaporative dry eye and aqueous deficient. With that, I will say thanks very much. If anyone's interested, there is my email address, and we'll hand you back to the moderator for us to deal with some questions. Thanks very much.
Okay. Murad, from your side, please.
Thank you. I believe this is very informative talks about DEWSII report. I believe DEWSII is our reference nowadays for managing, diagnosing, and treating dry eye disease. And I encourage the audience, if they have any further questions, to type it down. And we are lucky we can have access to these papers, and we can definitely use it in our practice. Saleh, I'll leave you to start with the questions.
Okay, beautiful. Thank you, Murad. I think we have received a good number of questions here and also on the WhatsApp group. Possibly considering the time, maybe we'll take 2 or 3 questions, and I will respect the first question that was sent to us. It is from Dr. Pavli Mowad. Basically, he is saying, as an ocular surface specialist, he is managing a lot of cases of Jogner syndrome. And his question was basically, any tips for diagnosing Jogner syndrome other than the Sherman test?
Okay, I can take that one. So Sjogren's syndrome is something that's very important for us to pick up. It's something that we're very slow at picking up. We know that it's years for most patients until they actually get identified. But there are actually strict criteria for how you diagnose a Sjogren's syndrome. So when we see Sjogren's patients, we tend to find that they have dry eye and dry mouth. So that would give you an indication. Certainly in your questioning, you should be asking about that. But for the criteria to diagnose a patient with Sjogren's, it is still a Schirmer test, I'm afraid, and it's requiring a level of less than 5 millimeters in 5 minutes. So that's without anesthetic. So if it's not meeting that criteria, then I'm afraid it probably doesn't actually meet with the current consensus criteria for Sjogren's. But it doesn't mean that the patient doesn't have a dry eye. It doesn't mean that they don't have ocular surface disease of some kind. So it doesn't mean that you can't manage those patients. You know, Sjogren's to some extent is a label. We need to know about that because of the systemic associations. But beyond that, as somebody with dry eye, even if they have a reduced breakup time or a reduced production, should be having some form of treatment. So yeah, I would tend to focus on non-invasive measurements as much as possible now.
Beautiful.
And it would be a biopsy, actually, would be your definitive one, would be a biopsy.
Well, in his question, in complete fairness, he was just questioning about the diagnostic part within the clinic. But of course, the biopsy will be confirmatory, definitely.
And now, staining. So you can use staining as well with fluorescein, as he's mentioned as well. You can use the staining, using fluorescein to measure and then to grade the level of staining that's present. And that, in a Sjogren's patient, that usually will be quite marked.
thank you. Another question from Dr. Ahmed Hayawi. Any relationship between COVID and dry eye disease?
I can speak to that one a little bit. Obviously, people in COVID have been spending a lot more time indoors, staring at computer screens. We also know that masks divert the airflow over the ocular surface. So again, mask-induced dry eye is a thing. Associated dry eye is a thing made. But in terms of the infection itself and dry eye, I'm not aware of any sort of direct link between those two.
Beautiful, thank you.
I have a question here, Saleh.
Sorry, Murad.
Sorry, you wanted to add anything, Professor Gomez?
Yes, I just want to add, Jenny, about the Sjogren's syndrome diagnosis. You know, we have the European and the consensus, the Sjogren's consensus. So that includes the biopsy, the Schirmer test, the staining, but also the production of saliva. That's a criteria. And another important and major criteria is the presence of the autoantibodies. So that's also count a lot in as a major criteria. So just when you sum few of these criteria, you can come up with a number, even according to the consensus, that can gives you the diagnosis or help the rheumatologist to close the diagnosis of Sjogren's. But for our eye specialists, of course, we are going to be more focused on the Schirmer and the staining, which is very important for close diagnosis of Sjogren's.
I have a question, maybe related to the pathophysiology, Professor Gomez. I have a question from Dr. Khalil Al-Hosani. He's asking about an explanation for patients who have signs of dry eye disease, but they are completely asymptomatic.
That probably comes under the definition and classification one. So I can take that. So these would be patients. So patients with ocular surface disease and without symptoms is either because they don't have enough nerves. So in dry eye disease, we recognize that patients can lose some of their nerves. They've got a less dense subbasal nerve plexus. So they're not feeling the same sensations as somebody with full sensitivity would. So it doesn't mean that they don't have a problem. It just means that they don't feel that. So that would tend to be why you would find that. Does that answer the question?
Definitely. Actually, a worrying sign. It tells you that the cornea is anesthetized. So you need to be aware and treat it. Not say, oh, patient is asymptomatic, why should I bother? I tend to take pictures for their cornea and show it to them and show them that they have a disease because they are completely asymptomatic.
And that's a fantastic point. That's exactly what we say. This is the beauty of classifying the patients in this way, is to help you manage your patients with your expectations and their expectations. Because if the average dry eye patient has the symptoms and the signs, and you can encourage them to comply with your treatments by telling them that they will feel better, and that's what drives their good compliance. But in this case, is exactly as you say. You're not going to get the compliance based on improved symptoms because they didn't have symptoms in the first place. So you have to rely on education, on imaging. That's perfect. Show them the pictures, show them what's happening to try and encourage the compliance with the therapies that you're introducing. Perfect.
Yes. And Jenny, that's exactly the example of the iatrogenic situation of the dry eye after LASIK. Right, that happens, and you can see very clear a lot of sometimes staining, and the patients, most of the patients are not complaining about the signs, and also that can happen in the initial cases of dry eye. Right, I think it's in the classification as well. Sometimes when dry eye is starting, you can have this type of situation. That you start to see some signs and you don't have a lot of symptoms, or the other way around?
You can get both. You can get it both ways around. Alternatively, you can have patients, more commonly probably would have patients complaining of some symptoms, but it's maybe in the early stages and we're not able to see the signs yet because they're just a bit too subtle. I think that's something you have to remember as well, is it depends on the equipment that you have available as to whether you're going to pick that up. Because if you're not using the most non-invasive, the most subtle tests or most sensitive tests you can, you're potentially going to miss the subtle signs. So we need to be looking as carefully as we can and watching out for any of those changes occurring, because once they have the signs and the symptoms, of course, they're in dry eye and they need to be managed according to the way we've heard from Professor Jones today.
Great, thank you. Saleh, do you have any other questions you want to add? Or?
Maybe actually the last question, and we can close here. It's almost 11 midnight, before midnight. And the question is coming is, when patients on topical cyclosporin or Xiidra, whatever concept is you're using, they started to improve and actually improve, they started to wean them, and then the symptoms come back again. So if there's any recommendations or tips on what to do in such cases?
Neither I guess of those is a cure. You can't cure dry eye. So you need to consider a longer term management plan. So if the patients are on an immunomodulator, they may need to continue that in the longer term. But what you need to be looking at round about is all the other things that could be going on, because of that vicious circle that Jose talked about, with all the things that are feeding into that. If you can tackle the different reasons why somebody might have a dry eye, by managing some of those aspects, you may get less dependence on some of these drugs like Restasis or for cyclosporin or Xiidra. But you generally don't come off it. You would, if you put somebody on steroids immediately, you would want to wean them off that because of the risks in the longer term, and you'd put them onto something like cyclosporin. But we do need patients to understand and clinicians to understand you're in it for the long haul with dry eye. If the patient is predisposed to that, they will continue to be, and it's about managing that as much as you can in the longer term.
Yeah, as I think Jenny made a very good point, for instance, topical cyclosporin, the Restasis, it takes weeks for you to achieve a result. So it's very, very important to educate, to tell your patient and that he's not going to feel the change in the first 1 or 2 or 3 weeks. And sometimes those medications are not cheap, and patients sometimes are not patient enough to wait until the medication start working. So it's very important in the first weeks, especially with cyclosporin, to start together with ocular surface steroid, a small amount of steroids in the first weeks. That is going to help decrease inflammation, and then you stop the steroids and you are going to start seeing the result of the topical immunomodulator. Yeah, we need to tell patients about this issue with most of these immunomodulators. Sometimes they take time to start working.
Beautiful. That's it from the questions we have here, Murad.
I think that's it for our evening today. Thanks again for TFOS for joining us today, giving us very informative talks about DEWSII reports, which is becoming now the reference for dry eye diagnosis, classification, and management. Thank you all. And for the audience, please, if you have any question, you can send email to Shurul from Novartis. I would like also to thank Novartis, who made a huge contribution to this evening and coordinated this with the speakers and the platform, as well as the CME certificate. Thank you, Shurul, and thanks, Novartis. Thank you, everyone, and have a great evening.
Thank you, Murad.
Thanks very much. Good night.